Treatment integrity is the degree to which a trained interventionist consistently and comprehensively implements essential intervention components. It's also known as procedural integrity, procedural fidelity, fidelity of implementation, procedural reliability, curriculum fidelity, and implementation integrity. There is a curious double standard in applied behavior analysis where we operationally define and measure the dependent variable, or the behavior, but not the independent variable, or that intervention that we're implementing. When we fail to assess treatment integrity, this poses threats to internal validity, which are other factors that influence outcomes, and we really must rule these multiple alternative explanations for behavior change out. So if an effect is observed, how do we know it's due to the intervention? And if an effect is not observed, it may have been because the treatment was implemented incorrectly. It also poses a threat to external validity, which are factors that prevent generalization. Treatments that are not described specifically cannot be accurately replicated. Now, PBIS evolved out of applied behavior analysis, and an important element in both fields is the operational definition of variables. Documentation of treatment integrity is an indicator of study quality, and between 1980 and 1990, only 34% of studies in the Journal of Applied Behavior Analysis even provided operational definitions of that independent variable. So they didn't even describe what that intervention was in such a way that it could be replicated and measured. 16% of those studies, of those 34% that actually defined the independent variable, only 16% actually provided treatment integrity data, and that's a very low number. Between 1991 and 2005, only 39% of school-based studies in JABA provided any mention of treatment integrity, with only 30% providing any sort of treatment integrity data. Between 1999 and 2009, 60% of studies in the Journal of Positive Behavior Interventions provided operational definitions of the independent variable, but only 42% provided the actual treatment integrity data. So you can see that there is an issue with not only defining the independent variable, but measuring it. So why is it important? One issue with treatment integrity is we can't replicate what we don't know how to implement. So if we aren't describing the intervention, then we can't replicate it. And this really creates a problem with the research to practice gap. Recent federal and state mandates for educational excellence, standards-based instruction, and high-stakes testing have prompted research and teaching communities to make more substantive commitments to school-based research. But we have less and less access to effective intervention description. Also, it's important to assess treatment integrity because we need to know if the problem is the intervention or implementation of this intervention. A vast majority of teachers display decreasing or low treatment integrity levels within 10 days after training. And so a lot of times teachers come to you and say, the intervention doesn't work. You need to do something else. And what we are finding is it's not the actual intervention. We are pretty good at designing that. It's the actual implementation. Something is sliding, and it's not being implemented as written. So if you take half of a heart pill instead of 2 heart pills, you're not going to have the same effects as if you take the prescribed dose of medication. The same is true for treatment integrity. So how do we measure treatment integrity data? There are several different ways that we can do this. The first is direct observation. So this is the most direct method, but it is invasive. We go in and we actually observe the teacher or the interventionist implementing this intervention. So we're another body in that room with the child or children and that interventionist. This does allow us to assess content and quality, Content is which steps of the intervention were implemented, and the quality is how well the intervention steps were implemented. So we're not only looking at if or if not the interventions in place, we're looking at the quality of the implementation. And there are 4 key steps to doing this. The first is to create a treatment integrity protocol, and this means creating a task analysis of those intervention components. So you get to use those task analysis skills in another way than just working with a child. You can actually do this when working with an interventionist, a teacher, a parent, anybody who's working with that child. Then you need to operationally define the intervention components. So you know each little piece of that intervention is described in such a way that anybody can walk into that room, observe what's going on, and know whether or not the intervention is being implemented with fidelity. Then you need to document the presence or absence of each treatment component and compute and report component and session integrity in the form of a percentage. So we need to somehow quantify how well that intervention was implemented, and that means assigning a percentage. Here we have an example of a treatment integrity checklist that's been used for phonological awareness training, and you can see that the components have been broken down in task analysis and numbered. Each day there is an X or an O to indicate whether or not the teacher implemented each component with fidelity. And then you can calculate not only session integrity, but component integrity. And so at the end of the week, you can go back and say, you know what, the weakest area in implementation is number 3, that presented picture cards in a correct sequence. And we can train up not only the entire intervention, but really focus on number 3 and work with that teacher or that interventionist to put those picture cards in the correct sequence, thereby increasing fidelity and ultimately increasing the effects of that intervention on student behavior. Another method to evaluate treatment integrity is to get feedback from consultants. And so a consultant is a person who is not responsible for implementation, and they are trained in the intervention components. The consultant observes the implementation and provides feedback. The more frequent the feedback, the higher degree of treatment integrity. And so it's not a once a quarter observation and feedback session. You need to do this often until you see consistent treatment fidelity in place in that setting. Now, this is labor intensive and it requires a third party, and that's not always feasible. School districts especially don't usually have a third party that can go in and evaluate treatment fidelity in all settings that have interventions in place. I don't recommend a principal or somebody that's responsible for job evaluations being that evaluator or that consultant, simply because it kind of muddies the water between administration and job performance and keeping your job and implementation fidelity and doing your job well in a supportive manner. So we always want to use the principles of ABA in consultation and make sure that we're providing direct feedback, opportunities to practice, and lots of reinforcement for appropriate behaviors. This is more important than punishing maybe low fidelity, which might happen if someone like a principal is the one observing the teacher. Another method is self-monitoring, self-reporting, and behavioral intervention or interview techniques. In self-monitoring, the interventionist tracks to what extent he or she implemented each component of the intervention using the same task analysis used in the direct observation method. So instead of me or you going in to observe the teacher or the interventionist implementing the intervention and marking whether or not it's in place, the interventionist is actually self-monitoring their own behavior. In self-reporting, the teacher self-monitors treatment integrity and then reports the findings to an administrator, consultant, or peer. So this adds another layer of accountability in that they're not only self-monitoring, but they're saying, you know what, these are my strengths and these are my weaknesses, and perhaps this opens up conversation with others who might be able to help support the interventionist or teacher in implementation. Finally, there are behavioral interviews, and that is a rating scale that is completed based on the observation of the entire treatment to monitor which intervention components were implemented as designed. In a behavioral interview, you're really going back after the fact to rate whether or not the intervention was in place, rather than doing so during the observation. So direct observation is I'm in there observing and I'm marking things in place or not in place during the entire observation period. And I can do it as a yes, no, or a rating scale, always, sometimes, never. In a behavioral interview, I might come and observe and then go back to my office and try to recall what was in place and what was not in place, and provide a rating. So here's another example of a treatment integrity checklist that one might use to self-monitor or self-report. You can see it's just a checklist. Mrs. Kimball will place a stop sign on the whiteboard, place the go sign on the whiteboard, such and such and such. And then there's a place for Chuck will, and the student needs to mark down whether or not he engaged in the intervention behaviors. And then Mom and Dad will. And so on this one form, you have self-monitoring and self-reporting for not only the teacher, but also the student and the parents. In this one, it's just marked as a yes, no. But you could certainly do a rating scale and maybe do 0 is never, 1 is sometimes, and 2 is always. This is a behavioral interview, which is a rating scale. I actually really like rating scales because sometimes it's not a simple yes, no. And this allows someone to go back and rate each component according to some sort of rating scale. Here they use percentages, and so teacher organized, classroom is per guidelines, and you have absent, present 11 to 25% of the time, present 26 to 50, present 51 to 75, and then 76 to 100. And so you can actually rate each intervention component, which once again allows you to look at those components that are maybe not as strong as others, and you can work with the teacher interventionist to train those components up. A final method to evaluate treatment fidelity is permanent products. This is the evaluation of products generated as a result of the intervention. So you're not actually watching or observing or monitoring the intervention itself. You're looking at the permanent products that result from the intervention. The products are evaluated to determine the degree to which all components were included, which means there are some minimal disruptions to the class or the therapeutic setting, but really limited interventions can be evaluated in this way. If you look here, you have one of those smiley face rating scales that students might do, or teachers, for self-monitoring, or maybe a teacher might fill it out for the student. And so it's looking at whether or not the student follows directions during each work period. And instead of looking at the intervention itself, you're looking at the effects of the intervention. And if he has enough happy faces, then you can say, the intervention must be being implemented as written because we're seeing great effects. The problem with that is you really can't determine that. He could have gone on medication. He could have moved to a new home. He could just really be having good days. This also doesn't let you look at whether or not the intervention is ineffective if there are no gains in behavior, because you can't see whether or not the intervention is being implemented by just looking at a permanent product that shows no effects. You can also use manualized treatments and interventions to evaluate treatment fidelity. These are interventions with explicit scripted protocols, and these scripted protocols really can increase treatment fidelity. The SRA reading series is, I think it's SRA, is one example of this, in that the teacher reads a script to teach reading, and students respond accordingly. A teacher or a consultant can evaluate each step in the script to measure treatment fidelity. So let's look at an example here. This is an example from a scripted lesson. And so it says, read the items. The items the children read are designed so that the children must read each word and remember the instructions given in the item. The tasks are presented so you can test the children to make certain they are reading carefully and comprehending. And so you would pass out storybook 1, and then where you see the orange or red text, that's what the teacher would do. So the teacher would say, open your book to page 85, and then it tells the teacher to point to the title and read the item. Everybody touch the title, and then you check the students' responses. I'll read the title. You point to the words I read. Get ready? Read the item. Okay? And so you turn and you read the title, first word, and you go through and you read the script, the students respond, and I could be sitting in the back checking whether or not you're saying each item in the script as written. Okay, so I'm giving you a challenge. I want you to find a behavior analytic article that describes an intervention, determine the method you'd use for collecting treatment integrity data, and compare this to what the authors did, if they did anything at all. Then, create a treatment integrity data collection tool for your chosen intervention. Email me a summary of the comparison and your treatment integrity tool for 5 points extra credit. I recommend screenshotting this so you have the directions later, or you can pause the video and go and do the assignment, the extra credit assignment, or however you are going to best remember how to do this, because we do have a few more slides left in this presentation, but I wanted to mix it up and not put it at the end so you can't fast forward to the end to see what the extra credit is during this lecture. So treatment integrity data can be used to assess efficacy and efficiency. Efficacy allows the observer or the researcher or whoever is implementing, it allows them to ensure the intervention was implemented exactly as planned. With efficiency, you're taking complex interventions from the contrived to the applied settings. So you're looking at that article, you are implementing in the clinic, and you're taking that intervention to a natural setting such as the home, the school, or the community. But you need to consider what elements of the intervention are essential to their effectiveness and what adaptations can be made to the interventions without sacrificing that effectiveness. Intervention adaptations may be more likely to improve intervention effectiveness than decrease it, which I think is a really important thing to realize. Treatment integrity data may show us which intervention components should be implemented as planned and which components can be adjusted. Now, there are some considerations with treatment integrity. One is that there are no truly set guidelines for how often to collect treatment integrity data. So should we collect frequently at first and then fade? Should we collect intermittently on a pre-specified schedule? Or should we collect based on performance? If we see the intervention slipping a little bit, is that when we go and assess? Or the behavior decreasing or increasing in the way that we don't want to see it increase or decrease? Do we wait until the student starts failing, essentially, to go in and evaluate treatment integrity? Treatment integrity data, so people say that treatment integrity data should be reported in research at least for a minimum of 25 to 30% of intervention sessions. And really, you should be collecting inter-observer agreement on treatment integrity data, a minimum of 30% of those sessions. There are some researcher-reported barriers to treatment integrity evaluation that we should know about because this does apply to the therapeutic setting. We do have limited knowledge of treatment integrity and its theoretical basis. There's also a lack of consistent guidance on treatment integrity procedures, and a lot of time, cost, and labor required to collect and evaluate this data. Finally, one issue that I think we're starting to address more and more as reviewers of research become more aware of the issues with treatment integrity is there's really a lack of accountability on the behalf of editorial boards. It's important that those that review research know that we should be evaluating treatment integrity and reporting it within these articles. So what happens when treatment integrity is low? Treatment integrity is a mediating variable between educational practices and learner outcomes, and the more consistency the intervention is implemented, the better the student outcomes. But there are factors that lead to low treatment adherence. These include intervention complexity. So if the intervention is so complex that there are so many moving pieces that a teacher or interventionist can't keep up, we will see a drop in treatment fidelity. So it's important that we design interventions that are actually feasible to implement in the setting that they're being designed for. Don't give a laundry list of recommendations, give specific intervention elements. We also need to look at implementation time required. Keep in mind that there are other things that teachers and interventionists have to do outside of perhaps implementing a behavior intervention plan. So if your BIP requires the teacher to spend 45 minutes a day implementing intervention, when is she going to teach the student reading, writing, math, etc.? So keep time constraints in mind for the setting that you are working in. Also, what kind of materials are required? Are they affordable? Are they easy to get? If a student destroys the material, are they easy to replicate or recreate? How many personnel are involved in the intervention implementation? Does the setting have an appropriate number of personnel to implement this intervention? We also need to look at the perceived and actual effectiveness of the intervention. If the teacher doesn't think it's working, she's not going to implement the intervention with fidelity. And so sometimes we need to go in and show the teacher maybe some data that really demonstrates the positive effects the intervention is having. Or we also have to realize that maybe it's not working. And we need to look at our own data and be able to determine whether or not the intervention is working. So put aside the ego and decide that maybe the intervention is not best for that setting. And then there's always the motivation of the treatment agents. So is the teacher motivated to implement this intervention? Knowing these factors, we can address low levels of treatment integrity. We can implement high quality training. We can work with the teacher to plan implementation and maybe roll out specific intervention elements slowly so that they get used to implementation and get feedback on the various elements of the intervention. Provide lots of performance feedback. Not just you're doing this wrong, but also describe what is going well and then use what is going well to beef up what is not going so well. Self-monitoring and goal setting are two really good approaches that teachers can set for implementation. You can support them in self-monitoring implementation and setting goals for percent of elements implemented. There are some studies that show negative reinforcement and so used to increase treatment fidelity. So basically, if you're implementing the intervention well, then you don't have to stay after school to do some additional training. And so it's taking away that additional training if implementation fidelity remains high. And finally, something that's kind of true to my heart is function of teacher behavior. So treatment fidelity is a variable, and it is a variable that can be measured, observed, repeated. Therefore, treatment integrity is really a behavior. It's a teacher behavior. So implementation of intervention elements is a teacher behavior. And we can look at those teacher behaviors in the same way that we look at student behavior, and that is looking at function. Why is that teacher implementing an intervention with low fidelity? In 2016, myself and Shannon Kunavatana conducted a study that looked at function of teacher behavior and adherence to specific elements, and how working with the teacher and function of teacher behavior not only increased fidelity, but also affected student on-task behavior. So we were in a self-contained special ed classroom for students with behavior disorders, emotional behavior disorders. This teacher was the third teacher in the classroom by January, and the class consisted of rotating centers, and the students rotated from desk to desk to complete worksheets. So each desk was a different worksheet, and they walked around the room completing each worksheet during each center time. There was a total of 5 students and 1 aide. Only 3 of those students were self-contained. I've actually assigned this article, and so go and read it, and you can get all of the details in the study, but I want to show you the graph. And if you look at baseline, you can see student behavior is all over the place. We have Archer is the open circles, Talon is the open triangles, and Hunter is the open squares. On the left hand side, that is the y-axis. You have the percent of not only treatment adherence, but also intervals on task. And then along the x-axis, or that horizontal line, you have the number of days that we were there implementing intervention with the teacher. So during baseline, the student on-task behavior was all over the place. Then we did some direct training in a class-wide intervention with the teacher, where we did modeling, provided feedback, did some more modeling, provided more feedback, a lot of training before and after school, whatever the teacher needed to beef up his implementation. And what we found was implementation stayed pretty low. It stayed really around that 60% mark, and we broke the intervention up into kind of 3 pieces. The setting, so having a clean and organized setting, reinforcement, so using the token system that we had put in place, and then lesson planning and delivering. Did he have lessons in place, and was he delivering them using best practices for instruction? After 5 days, which ended up being a couple weeks actually, of low implementation and seeing no effects on student behavior, we started looking at the teacher. So if the fidelity was low, we knew we needed to get the fidelity up. And so what could we do to support the teacher? And what we found was, when the teacher was not implementing with fidelity, and instead doing some of the things like worksheets or, quote unquote, pushing the buttons of students would become aggressive. They would end up in a restraint, and then they would be sent home for the day. When the students were sent home, the teacher had a really easy day the rest of the day and got to catch up on paperwork, got to run copies or clean the classroom or whatever it was he needed to do. This was a teacher that, because he was in a self-contained setting, he didn't get any breaks. He ate lunch with the students, he went to recess with the students, he went to specials with the students, so he did not have any sort of planning period, which means he was just falling further and further behind in his work. So what we did was we trained and reinforced each element of that intervention. So first we focused on the setting, and we helped him to organize and clean his classroom, and so that all he had to do was really maintain it. So when we had 3 days in a row where that classroom was organized, and that was the only element we were looking at, we moved on to reinforcement. So we taught, modeled, provided feedback, reinforced that token economy piece. And when the students were on task, they earned tokens. When they earned so many tokens, they got an extra recess. So we found the teacher was escape maintained. Again, whenever he sent the kids home, he had lots of time free in the afternoon. So by the students earning extra recess, which the paraprofessional took them out to, the teacher got a plan period. And so when the students were good, the teacher got what he wanted, and so it was important that the intervention was implemented with fidelity so the students' behavior would improve. Once we had the reinforcement piece in place, and it was pretty solid for 3 days in a row at 80%, then we moved on to lesson delivery. You can see throughout the function-based consultation that student behavior, while it improved, it maintained pretty variable until we had all elements of that intervention in place at 80% or above fidelity. So not only pay attention to those colored bars and look at the increase in fidelity, but look at the variability of the student behavior and how it tightens up and becomes less variable as more and more of the intervention is implemented with fidelity. I leave you with this, that the evidence supporting the importance of treatment fidelity has accumulated to a sufficient degree to warrant addressing this topic more formally in our graduate training program. So that's where you are now, right? You're in a graduate training program, and we're trying to train you in really best practices of behavior analysis and all elements that means. We propose a two-prong approach. One, expand or develop graduate level lecture and practicum courses to better train practitioners about best and or current practices in fidelity assessment intervention. And two, ensure research courses and experiences not only teach students research methodologies appropriate to their fields of study, but also expose students to behavioral science approaches more broadly. So DeGennaro, Reed, and Cotting, they had it right. Implementation fidelity is among some of the more important elements of behavior interventions. If we're not implementing with fidelity, then we're not implementing. And so I challenge you to really go forth and not only look at what the student needs, but also what the teacher needs to implement. When I develop behavior intervention plans for schools, I always make sure that I provide them a treatment fidelity checklist or rating scale alongside that behavior intervention plan, so that they are ready to not only collect data on the student, but also on implementation, so on themselves.